Our next area for discussion is depression. So we're going to talk about mild depression, severe depression, manic depressive types of conditions. First thing I want us to start talking about is a fairly normal or mild depressive type of response. When people get bad news, when they're told they have a bad diagnosis, when something happens to a loved one, we often see what I call the DABDA response. This is the response is described by Elizabeth Kubler-Ross, whom you may have studied in school. And typically the first response to bad news is, oh no, not me. This isn't happening. It can't be. They aren't dead. I don't have this disease. This is denial. And that's a normal type of response to an immediate type of bad news situation. This is often followed by anger. And in anger, the patient says, why me? And is very angry. They're asking, why me? Why is this happening to me? This is often followed by bargaining. So they'll say, oh God, if only you will let me live until my son graduates from high school, until whatever, I will. And it may be I will donate money to the church, I will do this. So they try to create a bargain. This, by the way, is a good time for teaching because the patient desperately wants to live, to overcome whatever the problem is. Then depression. Woe is me, I often call it. So people often wallow in depression for a while, get severely depressed. Then acceptance, and hopefully patients get to this point. Now, acceptance doesn't mean that they're giving up. Acceptance means that they say something like, the situation exists and I can cope, I will get through this. Now, unfortunately, people don't go 1, 2, 3, 4, 5 of those stages. They may have denial, anger, denial, anger, denial, anger, bargaining, before they move on to depression and acceptance. So there's a lot of moving back and forth as they go through this process. In, say, someone lost a loved one, they're apt to go through this kind of process. It may take a year or so to go through this type of grieving process. Now, personally, I don't ever like to see the word get over, because people don't get over the loss of a loved one. They don't get over a bad disease. What happens is they adapt to it. They learn to accept what's happened to them rather than get over. So I don't like to see that term getting over a problem being used. But in a normal grief type of reaction, a year is considered a normal kind of length of time. Could be a little more, a little less. If someone, however, is still in the acute grieving stage 4 or 5 years down the road, this may indicate some problem in going through these steps. Now, I want us to talk a little bit about depression in general. Most of us know what depression is like. There's probably nobody that hasn't been at some time in your life depressed. You've been sad. Nothing seems to make you happy. Now, a lot of you, and I might ask you, how many of you, when you are depressed, eat for comfort? And how many of you can't eat at all? So what we frequently see is a change in eating habits resulting in a change in weight. Some of you, when you are depressed, want to sleep all the time because that's the only time you're not hurting is when you're sleeping. Other people find that their mind just plays over and over and over what they're depressed about and they can't sleep at all. So we see a change in sleeping habits. So depressed people frequently have changes in eating and sleeping habits. They may also find that they either sit in the corner and do nothing, so they get psychomotor retardation, or sometimes they get agitated and they pace, so they may be pacing. Either one of these extremes can be characteristic of depression. Most people who are depressed have very little energy. They're tired. Most have feelings of worthlessness. Oftentimes, suicide, thoughts of death or suicide are present, you need to assess severely depressed patients for suicidal ideations. People that are extremely depressed can't concentrate. By the way, that's not a good state to be in when you're going to take exams, because you need to be able to concentrate and think when you're taking exams. Let's look at a question. A 52-year-old man is admitted to the psychiatric unit. He states he does not sleep well. He has not been eating and has no energy. He tells the admitting nurse, quote, "I don't think you can make me feel better. There's no use in talking to me. Leave me alone." What is the most appropriate interpretation of his behavior? The client, 1, needs solitude. The nurse should leave him alone. 2, is depressed. The nurse should stay with him. 3, needs encouragement. The nurse should assure him he will get well soon. Or 4, is in a bad mood. The nurse should tell him to cheer up. Now, the best answer is number 2. The behavior of this client suggests that he's rather depressed, and at this point you probably would stay with him. We want to do some assessment in terms of certainly of suicide potential for this patient. Now, as we talk about depression, people who are depressed, now unipolar means that they're depressed. Bipolar means that they have periods of elation or hyperactivity associated with that. Your major goal in dealing with people who are depressed is to increase self-esteem. And I often say that we have to do it, it's like building a brick wall. You do it one brick at a time. So we try to structure activities for success. So we'll give them something to do that they can achieve success on, praise them, congratulate them, and give them something else that they can achieve success on. So we structure for success. In addition to these types of activities, you want to make sure that they get the appropriate amounts of sleep, not too much, not too little. You may need to schedule their activities of daily living, particularly in the beginning. Left to themselves, they'll probably isolate themselves in a corner somewhere and not participate in many of the unit activities. The patient may be, and their family may be candidates for family therapy. Group therapy may be effective in depressed patients. We need to let the patient know that we accept him depressed and all. So unconditional acceptance of where he is at. And we encourage him to express his feelings. As he begins to express his feelings, hopefully that will assist the depression in lifting. Let's look at a question. When is a severely depressed client most likely to commit suicide? 1, when he is mute and unlikely to tell anyone about it. 2, when he is ready to go home. 3, when his family goes on vacation. Or 4, when he begins to demonstrate improvement. And the correct answer is number 4. When he's severely depressed, he frequently does not have enough energy to carry out a suicidal attempt. But as he begins to get better, he's still depressed, but he now has enough energy to carry it out. So as they begin to improve is a real danger time for potential suicide. A woman who is severely depressed begins to improve. Which of these behaviors might indicate an impending suicide attempt? 1, responding sarcastically when asked about her family. 2, avoiding conversation with some clients on the unit. 3, identifying with problems expressed by other clients on the unit. Or 4, appearing detached when walking about the unit. The correct answer is number 4. If a person is about to commit suicide, they have emotionally distanced or separated themselves from others, and appearing detached would suggest an emotional separation. The other answers all really indicated an emotional involvement. If you care enough about your family to respond sarcastically, And choice number 3 said identifying with problems expressed by other clients. If you're about to commit suicide, you disidentify, you separate from others. And choice number 2, I want you to take a look at that. Avoiding conversation with some clients on the unit. Some clients, avoiding conversation with some people is normal. So this doesn't say anything particular abnormal. Most people talk to some people and not to others. So that's perfectly normal behavior. Another question for us. A woman is being treated for severe depression. During the acute phase of her illness, which of these measures should have priority in her care? 1, keeping her in seclusion. 2, repeating unit routines to her in detail. 3, urging her to interact with other clients. Or 4, providing her with physical care. And note that it says during the acute phase of her illness. And the answer would be number 4, providing her with physical care, making sure that her basic needs are being met. Another question for us. An adult man is admitted to the psychiatric unit after expressing suicidal thoughts. He has become increasingly depressed since his wife was killed 5 months ago in an accident. His children, ages 3 and 5, have been living with his mother. He remains mute and does not speak to anyone. During the time he is severely depressed, which of these nursing measures is of greatest importance? Number 1, providing a cheerful environment for him. Number 2, encouraging him to participate in sports activities. Number 3, giving him a sense of being cared for. Or number 4, encouraging him to talk about his wife. Now, before you choose an answer, note what the question asked. It said, during the time he is severely depressed. And look back at the data. It tells you he remains mute and does not speak to anyone. So the correct answer for this question is number 3. Give him a sense of being cared for. Help him recognize that he's worthy of your attention, of being cared for. The answers that talked about talking about his wife, he doesn't talk. They told you twice he doesn't speak. Providing a cheerful environment is not going to be an answer, correct answer for questions for depressed patients. Because you come in and you say, oh, good morning, it's a nice cheery day outside, look at the sunshine. This is not going to cheer up a depressed patient. It just, well, it's not cheery to me. Sun isn't shining bright for me. And it's not going to be a particularly effective mechanism. So don't choose that kind of an answer. When he's severely depressed, sports activities are probably not a realistic option. You simply have to go way back to the beginning and give him a sense of being cared for. That's the beginning of helping him increase his self-esteem. Another question for us. An adult male is being treated for depression. He has been in the hospital for 3 weeks. Which observation by the nurse is indicative of improvement in his condition? 1, he appears for breakfast unshaven. 2, he says, I now have the answer to my problems. 3, he refuses to eat, saying, I don't like hospital food. Or 4, he initiates a conversation with another client. Now the question asked us indicative of improvement, and that would be choice number 4, that he's reaching out, he's interacting with others. Answer number 2 that says, I now have the answer to my problems, that should make you very concerned about the possibility of a suicide attempt. Another question for us. An adult is being treated for depression. One day he appears at the nursing station and gives one of the nurses his favorite book. He smiles happily and says, I want you to have this. The nurse's response is based on which understanding? 1, nurses should not accept gifts from clients. 2, His actions indicate an improvement in communication skills. 3, the nurse should support actions which bring the client obvious pleasure. Or 4, giving away objects of personal importance is a suicidal warning sign. And the correct answer is number 4. This should set off alarm bells in your mind when they're starting to give away treasured objects, particularly if they say that, they aren't going to need it type thing. So this would be a suicidal warning sign. Patients who are depressed are frequently treated with antidepressants. Tricyclics are a major group of antidepressants. These usually consist of the ipramines and triptylines. So if you look at the names of those drugs, you'll see ipramine and triptyline. Amitriptyline is Elavil, which is easy to remember because it elevates the mood. Now these tricyclic drugs, in terms of side effects, I think you should remember they have anticholinergic side effects, so the red hot, dry, blind, mad type of side effects. They can often cause some cardiovascular effects. They may drop blood pressure. Photosensitivity is a problem with some of these, probably not quite as bad as those antipsychotic drugs, but it's still an issue. And it takes 2 to 4 weeks to be effective. Sometimes I say try cyclics, try weeks as a memory tool. Now, when we talk about antidepressants, there are some other groups, the monoamine oxidase inhibitors. These are drugs like the Marplan, Nardil, Parnate type of drugs. These are very, very powerful antidepressants. They also have a lot of interactions with other drugs. So when patients are getting these MAOI, monoamine oxidase inhibitors, before they start on these drugs, they're going to be on a drug holiday from other drugs for 2 or 3 weeks. Other major side effects of the MAOIs, if the patient contains or consumes food that contains tyramine, then they're apt to get a hypertensive crisis. So any aged foods, things such as aged cheese, alcohol, fermented foods, you don't want them to have yogurt, chocolate, yeast, raisins, bananas. These can all cause a hypertensive crisis. So would you want to take this patient to a wine and cheese party? No, they can't drink the wine, they can't eat the cheese. Now, in addition to those types of side effects, we see severe anticholinergic side effects, the red hot, dry, blind, mad. Central nervous system side effects, they may have sedation to start with, and there are many, many drug interactions. So it's extremely important that patients taking MAOIs let any physician prescribing for them know they're on that drug and ask specifically, is this drug safe to be taken when I am taking an MAOI? A question for us. An adult is scheduled for electroconvulsive therapy tomorrow. Which statement made by the client indicates understanding of the procedure? 1, I won't eat anything after dinner this evening. 2, I will be so glad to be all well after tomorrow's treatment. 3, I don't look forward to jerking all over the place. Or 4, I hope I don't die when my heart stops beating. The correct answer is number 1. When patients are going for electroconvulsive therapy, they will be NPO the night before the treatment. They will sign a permit, and then you'll prepare them just as you would for surgery, so they're going to be NPO. Now, ECT, or electroconvulsive therapy, is an extremely effective means of treating severe depression. Studies show us that ECT is more effective than drugs alone, and when you combine ECT and drug therapy, it's extremely effective. And when a patient is going in for an ECT treatment, their MPO, before they give them the muscle relaxants and anesthesia, they're likely to put a blood pressure cuff tightly around one arm. This is to block the blood supply to that arm temporarily, which means that then when they give them the muscle relaxant, no muscle relaxant will go down the one arm. When they give the electric shock in a few minutes, what's going to happen is that one arm is the only part that's going to jerk. So we know when the one arm does the jerking that the electric current did indeed go through the body. But the muscle relaxant will keep the rest of the body from undergoing a grand mal seizure. So the patient has got the blood pressure cuff tightly around one arm to prevent that one arm from getting the muscle relaxant. The rest of the body is got muscle relaxant so that it's not going to have that huge grand mal seizure. They are given anesthetic. They have no memory of the treatment. They're asleep during the treatment. When they wake up, they will have some temporary confusion. So you will need to orient them as to time and place and let them know the date and the treatment is over with. They're all finished with it. Now, patients don't get better in one treatment. It takes 10, 15, 20 treatments for the depression to lift. Exactly how it works, I don't know if we know exactly what it does, but it probably alters the neurotransmitters and seems to be, as I said, more effective than drugs alone for severe depression. And it's really quite safe. Even though it sounds terribly barbaric, it's a quite safe type of treatment. I want us to think a little bit about clues to suicide. We had a couple of questions that dealt with suicide, and we need to pull that out a little bit more because this is a safety issue that's likely to show up on test items. Some people, before they commit suicide, will come right out and tell you, I'm going to kill myself. And this is how I'm going to do it. And they proceed to outline their plan. If someone tells this to you, you need to take them seriously because some of these patients will indeed do exactly what they say they're going to do. Some are a little less direct about it. They'll say things like, I found the solution to my problems. Tomorrow at this time, I won't have a care in the world. They'll come out with those kind of responses. Some patients will actually make minor suicidal gestures to let you know how much they're hurting. They might lightly cut their wrists. They might do something that is, take 5 pills. Well, 5 pain pills isn't going to kill you, probably. 25 might, but 5 is probably not going to do it. Some people give the message by more indirectly. They give away the objects that are important to them. Now, it says on the slide that making a will is a sign or a clue to suicide. Now, most of us should have wills. Wills are something that's a normal part of planning. However, if a severely depressed patient becomes extremely concerned about their will and wants to rewrite it and make sure everything is right with that, that's what gives us pause for concern. Now, if you think a patient is about to attempt suicide, do you need to get a doctor's order before you can put out suicide precautions? No. If you think someone is about to commit suicide, you may institute suicide precautions. And suicide precautions, we want the patient under observation. You want to remove harmful objects. Now, I want you to think about what type of objects would you remove. So you remove anything that's sharp, scissors, knives, plastic knives that they could cut themselves with. So any type of sharp objects. Make sure they don't have razors and razor blades available. You also want to remove anything they could hang themselves with. So you want to remove shoelaces, belts, bed sheets, because frequently patients will tie the bed sheets and hang themselves with bed sheets. So the harmful objects would be anything they could hurt themselves with, not only the sharp things, but also the hanging kinds of things. Obviously, you would supervise any necessary use of sharp objects, such as shaving type things. A young woman says to the nurse that at times she wishes she were dead. What is the initial nursing intervention? 1. Call the doctor about her suicide ideations. 2. Assess further her suicide thoughts and ideations. 3. Assign a one-to-one to stay with her. Or 4. Have her sign a suicide contract. The correct answer is number 2. Assess further her suicide thoughts and ideations. Now, if a patient is saying something that makes you think they might be suicidal, you say to them, sometimes when people are feeling sad, they feel like harming themselves. Are you thinking about hurting yourself? You might go on to say, do you have a plan? How would you do it? Those are probably the most difficult things you'll ever ask a patient, but they're very important. You want to know, are they thinking about killing themselves, and how viable is their plan? So how close to fruition are we on that plan? There was a choice on that question that said assign a one-to-one to stay with her, and you might do that. But that's not your initial intervention. Now, we do frequently have employees who are sitters who are hired to simply observe suicidal patients. They aren't hired to be therapists. They're hired to be your eyes when you can't be in every patient's room 24/7. So they are hired to observe patients and call the nurse if there is any indication of attempt at suicide. One answer on that question talked about a suicide contract. Now, this is a contract not to commit suicide, not a contract to commit suicide. And sometimes we know that when patients are desperate, they aren't thinking clearly. So we will help them outline who they're going to call, where they're going to go for help. Maybe the name and number of their psychiatrist, their social worker, their clergyman, their best friend, their relative, someone that they will call for help. And maybe there are several numbers there. And then we drop a little contract. I agree that I, so-and-so, will not attempt to hurt myself without first contacting these people. And then they sign the contract. Obviously, this is not a legally enforceable contract, but having those resources readily available and having signed the contract often makes people stop and think before they attempt suicide. I want us now to talk a little bit about bipolar disorder, oftentimes called manic depressive, sometimes called elation depressed. When we talk about the manic period, this is abnormally elevated mood, and it persists and it interferes with functioning. For some people, this alternates with depression, so that they have periods of elation where they're really hyper and overactive and very hyper, and periods when they are rather depressed. Now, when they're in the manic stage, people have a very quick wit. They can talk about any subject. They often have a flight of ideas, so they go from one subject to another. So if they were talking about seeing the birds flying, oh, flying now, the last time I flew to Europe. Oh, Europe, did you hear about the European Union and what's going on with the European Union? Oh, let's talk about the union, the labor union, AFL-CIO, what's going on. So you see what happens is their thoughts go from one subject to another. They never stay on any one very long, and they just move, flight of ideas. They are apt to be aggressive, argumentative. They can get irritated very quickly. They anger quickly. They are often have excessive motor activity, so they're pacing, they're moving, they're running, they're always on the go. And they really tell you they can solve all the world's problems. If you just let them call the President of the United States, they could solve the whole problem. Every problem around the world could be solved because they know the answer to all these problems. Now, when patients are in this manic state, the nursing action has got to be to set limits. Decrease the stimuli because they feed off from stimuli. So if there's a lot of excitement in the air, whoa, these patients are really off and running. We have to help them meet their basic needs, including food and bathing. So they might need finger foods. Sometimes when people are in a manic state and their just thoughts are going from one thing to the other and they're talking extremely rapidly, we may pace their speech, which means that at first we'll match their speech. So if they're talking extremely rapidly, we'll talk extremely rapidly, and then we will gradually slow the pace of the speech. And sometimes they will follow us and slow the pace of their speech as well. We may try to redirect thoughts, but please don't argue. You would never win an argument with a manic patient. Let's do a question. An overactive client is in the day room with several other clients. Now, when you see the word overactive, that's kind of a code word for manic. So this manic patient is in the day room with several other clients. He begins to outline plans for organizing a political rally. No one pays any attention to him and he becomes frustrated. Which behavior should the nurse expect he will demonstrate when frustrated? 1, hostility. 2, giving up. 3, isolating himself in his room. Or 4, seeking consolation from the nurse. This patient is manic. He will, number 1, demonstrate hostility. He will become hostile and angry. Another question for us. A 42-year-old woman has been admitted to the hospital because of recent overactive behavior. She is too busy to eat or sleep and has lost weight. She has been hospitalized in the past for the same problems. She is talking continually. Her speech is witty, sarcastic, and covers many topics. On admission, the nursing care plan should have which of these measures as a high priority? Number 1, encouraging her to select which activities she will do. Number 2, keeping her under constant surveillance. Number 3, minimizing stimuli in her environment. Or number 4, encouraging her to interact with other clients. And the correct answer is number 3, minimize stimuli in her environment. She will feed off from stimuli in the environment. So let's keep it as calm as possible. Another question for us. A woman is admitted to the hospital because of recent overactive behavior. So now you're going to think manic. She enters the dining room for lunch after everyone is seated and eating. She runs around telling everyone that she's just been invited to speak in an important political meeting. She then sits down and starts to eat. After taking a few bites, she gets up and walks quickly out of the dining room. What initial action should the nurse take to meet the client's nutritional needs? 1, serve her meals in her room. 2, give her finger foods to eat. 3, sit with her while she eats. Or 4, discuss the importance of eating with her. And the correct answer is number 2, give her finger foods, give her a sandwich, give her something that she can carry with her. She's unable to sit down long enough to eat a meal. Most patients who are manic are likely to have lithium prescribed for them. Now, lithium drugs are easy to recognize because they all have the word lith in their names. So the trade names all have the word lith. Initially, when the patient is started, we're probably going to be doing daily serum lithium levels, and the blood work will be drawn about 12 hours after the last dose. Blood levels, our target goal is somewhere usually between 0.6 and 1.2 milliequivalents per liter is considered the therapeutic dose. Levels above 1.5, we may see some toxicity. By the time you get to 2.5, they can be fatal. Now, toxicity to lithium can include everything from gait disturbances to GI tract disturbances, and at high levels you can get cardiac dysrhythmias, cardiac arrest, and death. A question for us. Lithium carbonate is ordered for a client with overactive behavior. The nurse should observe her for which of these side effects, diarrhea, rhinitis, glycosuria, or rash. Now, of those listed there, the best answer is number 1, diarrhea, your GI tract side effects. Rhinitis or a runny nose is not common, nor is a high blood sugar or a rash. Now, when patients are taking lithium, there's some important teaching we have to do for the patient. First off, it takes several weeks to reach therapeutic levels. So in those first few weeks, they'll be getting daily blood work. Once the levels are at therapeutic levels, then they will be getting periodic blood work to make sure that it's still in the appropriate range. We want to encourage patients not to drive until the lithium level is stable, because there may be some initial drowsiness as they start taking the drug. Lithium is excreted from the body as a sodium salt, which means that you would not want to put the patient on a low salt diet, because when you do, then the patient is not excreting, they don't have the sodium to excrete the lithium, and they can get high lithium levels and go into lithium toxicity. It's dangerous to give these patients drugs that are going to affect fluid and electrolyte balance. So diuretics are a problem for these patients. Caffeine can be an issue for the patients. Most patients who take lithium will gain weight. It's not a terribly adverse effect, and they don't get super fat, but they do tend to get just a little bit pudgy, usually when they're taking lithium. Obviously, you're going to notify the physician if there's signs of toxicity, and you must teach the patient about signs of toxicity. It's very important that they take their drug regularly and they maintain it within the therapeutic levels. Lithium helps to control this manic behavior in many of your manic depressive or your elation depression